Okay. All right. Good morning, everyone. I'm Dr. Basam Yaghmoor, a medical graduate, class of 2020 from Saudi Arabia. It is my pleasure to present today's topic, which is functional neurological disorders. Yes, I'm sorry. So I will be talking about definitions and what other names functional neurological disorders have, and how can they present, and the long road to diagnosis, including the criteria, signs on examination, pitfalls, and attitudes that we have usually in healthcare towards these disorders. We'll also go through pathophysiology and the outcome of these disorders as well as treatment. All right. What do you mean? What do we mean by functional neurological disorders? This is a relatively new uh, name for these disorders. Perhaps the older name was hysteria, and you know that hystero comes from the uterus in ancient Greek, and this was related to the wandering womb theory. In ancient Greece, they thought that the uterus moves with emotions. So it moves forward, for example, when there is a beautiful smell or there are positive emotions like attraction, etc., and vice versa. However, this is obsolete now and it has been abandoned, although the term hysteria is sometimes used, which we should avoid, in my opinion. But also we can call them conversion disorders or dissociative seizure or motor disorder. Sometimes we call them psychogenic, psychosomatic disorders. Also non-organic or non-epileptic seizures, for example, or medically unexplained symptoms. And there are some other terms that may be related, but they have different definitions. These terms include somatization disorder, which was in DSM-4, and it was changed to somatic symptom disorder in DSM-5, which is the reference for psychological diagnoses. And what characterizes this disorder is that it has the excessive preoccupation with the symptoms. So the patient is very concerned about certain symptoms out of proportion. There is also illness anxiety disorder where the patient is concerned that he is ill while in fact he's normal and healthy. Of course, we know factitious disorder, Mannhausen syndrome, and malingering, which are different. They are not the same as functional neurological disorders that are the patient has no control over them relative to these disorders. All right, functional neurological disorders, how can they present? The presentations can be motor. So maybe we have weakness or complete paralysis. We may have abnormal movements, so involuntary movements like tremors, shaking, whatever. Also, we can have swallowing difficulties and speech difficulties, as I will show you now. The symptoms can be sensory. We can have sensory loss, as well as paresthesia, so tingling, pins and needles sensation. Also, we can have visual, olfactory, abnormal smells or anosmia, and auditory symptoms, positive or negative, like hearing loss or ringing or other symptoms. Speech abnormalities, as I just mentioned, altered consciousness. So we may have patients that appear in coma or having seizures, like some patients we saw in the office. We can also have cognitive issues like memory loss that is functional. We can also have a mix of all these presentations. So diagnosis, how do we arrive to diagnose a patient with a functional neurological disorder or conversion disorder. The latest criteria that is in the DSM-5 includes symptoms of altered voluntary, so the patient having a choice, motor or sensory function, but they require certain things like evidence of incompatibility between symptoms and recognized conditions. For example, we have MS. In MS, we see lesions on the MRI that are correspondent or congruent with the presenting symptoms. But if we have a conversion disorder patient, we see the MRI is normal, but they have some symptoms. That is one example. And they must be unexplained by another medical or mental disorder. And they have to be, as in all psychiatric disorders, they have to be clinically significant to cause distress or dysfunction, so impairment in function or in the patient's life, or they may need medical evaluation. So what we conclude from this criteria that all patients need full and proper workup. We cannot arrive at the diagnosis of a functional neurological disorder or conversion disorder without the proper workup. All right, so what are some pitfalls we have to prevent? We must not miss organic neurological disorders. So some patients, as well as the functional neurological disorder, they may have a coexisting condition like stroke, multiple sclerosis, tumors, infections. Also, they may have psychiatric disease that is causing these symptoms, or maybe completely separate and independent of these symptoms. For example, we may have patients with panic attacks that complains of tingling, which is caused by hyperventilation, for example. What about other symptoms or elements of history, like stress, trauma, anxiety, and depression? Are they necessary? Do we necessarily have to have them in history? The answer is no. Not all patients have triggers that we can find. In fact, the opposite may be true, as it is mentioned in previous classes. There is what's called labile indifference. So we see the patient is indifferent to their symptoms, indifferent to any psychological trauma that they may have had, which is opposite to what we might expect. What is reassuring is that by the criteria I just mentioned, the diagnosis is fairly reliable, and studies showed that the misdiagnosis can be present in from 0.4 to 4% of patients. All right, so what are some signs? So there are so many signs, but I will just mention some of them just to give you some idea. There is Hoover's sign. In Hoover's sign, the patient presents with, for example, a unilateral leg weakness, and we see this weakness in extension of the leg. So when we ask the patient to extend the weak leg, they won't be able to do that. But when we ask them to flex the opposite limb, and we put our hand beneath the weak leg, we will see that the weak leg is actually extending. The muscles are working. So when they intend to move it, it's not moving, but when they are unconscious of the weak limb, they move it actually. I will just open the laser. Yes. There are some signs that are most associated with functional tremor. I will go over them shortly. In psychogenic non-epileptic seizures, there are specific features that are well known, like the eyes will be closed, the head moves side to side, perhaps the patients will cry on recovery. There are other signs as well that you can go through in the references. There is an interesting test that is called hand dropping. So we carry the hand of the patient and we drop it on their face. This is to elicit whether the coma, a patient in a coma, is in functional coma or is it true coma. So if the patient has functional coma, the hand will not drop on their face, they will put it somewhere else. On power exam, there may be variable resistance if the patient is complaining of weakness. As I said, there may be unconscious movements. There may be drift in the examination without pronation. Giveaway weakness. The patient may have normal power in the beginning of the power exam, but they suddenly become weak. Inverse pyramidal weakness. We all know that the upper limb in stroke, for example, the upper limb, the flexors are usually stronger. So the patient will flex his upper limb and extend his lower limb. In functional weakness, the opposite might be present. Also, loss of midline vibration sensation. So it's very unlikely or nearly impossible to lose vibration sense in the midline. So if the patient has unilateral sensory loss, and we put the tuning fork on the middle of the skull or the sternum, and they say they don't feel the vibration, it's likely that this is a functional vibratory loss or sensory loss. Okay, this is a video for what's called intranability. What they mean by intranability that the you will see the frequency or the type of tremor will change. I will just open the video. You can see the trunk movement will change in frequency to match the frequency of the hand movement. See? So the trunk is moving with the hand. While the rhythm before this was different. This is distractibility, which is often used in many disorders. Notice the right hand is moving, but in a few seconds, when she's thinking, see, it stopped while she is thinking sort of hard. This is suggestibility, and we saw that yesterday, and I saw it personally in another patient with functional tremor. So the doctor will say to the patient that when you feel the vibration, the tremor either will stop or will come around. See? So the patient was not shaking, but when he put the tuning fork, after suggesting to him the effect, the tremor came around. All right, what about some epidemiology? The incidence is quite low, but we see that in psychiatric settings, it is maybe double or more. And functional neurological disorders actually comprise the second most common reason to see a neurologist. So it's they are very common presentations, and 5 to 10%, and maybe actually higher in some studies, of neurological consultations are functional disorders, and 20% have comorbid neurological disorders. So it is really important to exclude coexisting conditions and work up these patients fully. The incidence is in females to males is 3 to 1, but in later life, the incidence is the same. All right, so what are the attitudes that are present in, towards functional neurological disorders among healthcare professionals? So in the right diagram, there is a study that assessed clinical interest as well as negative attitudes and negative experiences in all these professions. So neurologists, psychiatrists, and other professions, including general practitioners, we can see clinical interest is relatively high. Uh, Negative experiences are a bit lower, but negative attitudes are sort of in the borderline. So two indicates neither agree or disagree. And here, and this is, I think, is intuitive, 73 of the sample size said that they did not have enough education about functional neurological disorders. And we know very well that the recognition of these disorders was not very good in the past, but hopefully this will change in the future. In another study, they found that there is some interest and perception of importance of the therapeutic relationship between doctors and patients, but the patients felt that the doctors often just refer patients to online resources and they don't actually communicate with them. And they said that the clinicians don't care properly about the triggering life events, which can teach us something. The students, of course, had only scant knowledge of what are functional neurological disorders, and hopefully this will change in the future. All right, so how does functional neurological disorders arise? I put a simplification. Actually, there is some consistent evidence in recent studies, uh, especially functional imaging. So what is consistent in these studies, they see that there is ancillary or like auxiliary activation of the limbic system and the association cortex, uh, which is unusual. And I will clarify this shortly. And there is hypoactivation of the corresponding cortical areas and their thalamic connections. So when a patient wants to move, the usual activity in the brain will be, for example, the primary motor cortex and the other associated cortices. But in these patients, the limbic system is hyperactive and the cortical area, for example, the primary motor cortex, is hypoactive. And the amygdala is consistently hyperactive in those patients. The amygdala encodes emotional significance. So if the amygdala is hyperactive in a certain event, you will feel a strong significance of this event, and it will have a profound impact on you. And it affects the autonomic system as well. Um, and the thalamus is hypoactive, so of course we know all the pathways go through the thalamus. So if the thalamus is hypoactive and doesn't send these electrical activity to the cortex, we will not have the usual function. About the psychological aspect, there is a study from the American Journal of Psychiatry in 2006. They put sort of a possible pathway. This is not true in all patients, but it can guide us. So they proposed that there may be accumulation of life stressors, abuse or trauma, followed by suppression of expression. So the patient suppress those problems, and afterwards an impairment develops in emotional processing. So they don't process the emotions properly in the brain. And this interferes with the normal modulation of emotions and movement and sensation. And in the end, they will feel not in control. So they feel loss of control over themselves. And the brain will have some other connections that produce sensory symptoms, motor symptoms. And this goes into a vicious cycle that feeds into itself and worsens the conversion disorder. This is why early diagnosis and treatment provides better outcome. This is a very recent diagram of the areas involved in the abnormal activity. We see here the limbic system, as well as other symptoms, systems and areas. And there is increased interaction between these areas that result in the different symptoms. We see here that the amygdala in patients is much hyperactive in functional neurological disorder patients compared to controls. So these people saw negative faces that show negative emotion. The patients with conversion disorder responded with much higher activity in the amygdala compared to controls. And here the patient has a functional weakness of the right hand. When the right hand is supposed to be moving, there is a different kind of activity. You see here in the right, or maybe the opposite. Sorry, the opposite. When they are moving the right hand, the left hand. Sorry, the right is minimally active, just here. You see, compared to when the left hand or right hand is moving. So this is the left cortex. And this is the right cortex. So the left hand shows a little activity compared to when moving the right hand, which is now. All right, we can see here the same thing. Red indicates the moving right more than the left. So this patient has weak right ankle. The left cortex, we can see, is minimally active, and the activity is not focused in the primary motor cortex. It's widespread compared to the right cortex. Lastly, we'll go to treatment. This is a nice diagram from a recent article. The treatment of such patients, we may divide it to two divisions. We will have the core symptom, the primary or chief complaint, as we say. But we will have other symptoms that include fatigue, pain, cognitive fog, or sleep disruption. But we will have social factors, psychological factors. If you put them in medication, we have to monitor for adverse effects. And the beliefs in patients that involve the symptoms are very important. And they interfere with treatment, and it can interfere with the outcome as well. And I will elaborate on this. So treatment begins with validation. We have to validate the symptoms of a patient. We do not accuse them of lying or malingering. And this provides us, or provides the patient, education. So we have to educate them about the origin of those symptoms. We can't say this is all in your head, for example, but we have to mention that these symptoms arise from problems in emotional processing, problems in brain connections. And this also helps the trust between the patient and the doctor. And of course, follow-up is much needed. So it is very important in the long run. And of course, we have to identify stressors if they are present. This may require social intervention, psychiatric intervention. Cognitive behavioral therapy is supported by evidence. It can benefit many patients, and I will elaborate more. Physiotherapy as well is very important, and I will elaborate on it more. Repetitive transcranial magnetic stimulation. So as we saw, the pathophysiology involves hypoactivation of the affected cortex. So what if we stimulate this cortex? We see that a few studies that actually have done this resulted in very high response, but the evidence is still in its preliminary stages. And of course, we have to treat coexisting conditions like depression, anxiety, and other neurological disorders. So what about cognitive behavioral therapy? Um, of course, it helps the patient understand the diagnosis and where it came from, but also it is important to help the patient develop the skills needed to cope with stress, not suppress it and uh, allowing it to manifest itself in somatic symptoms. It was actually seen that cognitive behavioral therapy works best for episodic conditions like psychogenic non-epileptic seizures. Group therapy was shown beneficial for functional memory disorders, which is one of the cognitive functional disorders. What about physiotherapy? Well, physiotherapy, it is a bit different from the usual physiotherapy. So in physiotherapy that we offer patients with stroke, for example, we motivate the patient to move the leg or move the limb that is affected, and we encourage them to focus on the limb and increase, motivate them to move it. However, with patients with functional neurological disorders, this does not work. It is actually counterproductive and may worsen the deficit. So the physiotherapist usually needs to have special training, and they utilize unconscious movements instead of focusing on the moving the affected limb. So when they drive the focus away, the patient may notice that they are moving the affected limb, and this will help them. Uh, about repetitive transcranial magnetic stimulation, it targets the hypoactive areas, as we said, and there are just a few studies, but the reversal of deficits, in some studies it was immediate, in some studies it took months, and the response rate varied from 25% to 89%. There is only one study that I found that included placebo, and actually placebo produced some improvement. So the improvement was 10% compared to 25%. So the placebo effect may play a role in the therapeutic effect of transcranial magnetic stimulation. But of course, it is physiologically sound that it may actually help the patient. What is the outcome after we treat all these patients? So as we said, early treatment improves outcome. Uh, but what is also important, the patient's conviction. If they believe that symptoms are physical and they actually have a problem in the limb, or they believe that they won't recover, or as I said, they won't recover, or the problems are physical in the limbs themselves, this can worsen the outcome in 13% of the patients. So it's very important to educate the patients and um, inform them from where these functional disorders arise. Um, One example of for these patients of coexisting conditions, about 15% will have depression and or anxiety in their lifetime. So about half of those patients will have depression and or anxiety. So this is sort of a negative outcome. However, comprehensive psychotherapy in functional seizures or psychogenic non-epileptic seizures, in some studies resulted in complete resolution of the seizures in half the patients. by ending the psychotherapy. So the number may actually be higher. However, in the long run, there is a recurrence, but the numbers are not fully described. I will finish now by inviting you to support these foundations. This is the Functional Neurological Disorder Society in the US, and this is the FND Hope in the UK. And actually, in this year, they announced April as the FND Hope World FND Month. And there is a huge movement for helping research in this area and helping patients. These associations also offer group therapy and peer support. The last slide, it's an excerpt from Dr. Hal Blumenfeld in his famous book, Neuroanatomy Through Clinical Cases. He said, it is important, once again, to be cautious because lesions in the nervous system often present with atypical or unusual symptoms, as we all know, and signs for a given location, leading to apparent inconsistencies in the exam. So this is expected even in the usual neurological patients. Then he says, finally, it should be noted that a substantial number of patients have disorders in which neither a clear-cut neurologic nor a psychiatric diagnosis can be made. Patients of this kind are in danger of being treated by neither neurologists nor psychiatrists, who both may consider them out of their area of expertise. A better approach would be for these patients to be followed by both neurologists and psychiatrists until either a clear-cut diagnosis emerges or they respond to empiric therapy. Functional neurological disorders are quite new to our perspective and our understanding. So these patients are at risk of being ignored or untreated. What we should do is care for them and follow them and work them up properly and provide them all the support, whether clinical or outside the healthcare area, until their issue gets resolved. Thank you for this great opportunity again. It is my tremendous pleasure being a part of this rotation and working with all of the students and faculty. Thank you again, and thank you. And sorry for taking so long. If there are any questions, I welcome